am Dr. Satya Routray, Professor and Head of the Department of Cardiology at SCV Medical College, Cuttack, Odisha. As per WHO, nearly 63% of the total deaths in India are due to non-communicable disease, of which 27% are attributed to cardiovascular disease, which affect 45% of the people in the age group of 40 to 69 years. High blood pressure is among the most important risk factors for cardiovascular disease. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has also gone up to 32% in women and 38% in men over 30 years of age. Despite that, nearly half of the people, that is 51% of men and 41% of the women with hypertension, were unaware of their condition. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide, as reported by WHO in Lancet 2021. International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guideline. The inclusion of optimal and essential treatment paradigms attempts to address the issues in resource-poor settings. Optimal care refer to the evidence-based standard of care, and whereas essential care refer to minimum standards of care for low resource settings, so that every person can get the treatment and control the blood pressure to the target. The AHA and ACC has released a scientific statement in 2021 offering new guidance for the management of stage 1 hypertension among patients with low ASCVD risk. Among low risk adults, that is no ASCVD or 10-year CVD risk less than 10%, with stage 1 hypertension, the management starts with non-pharmacologic therapy. Here I want to say, but in stage 1 hypertension, there is blood pressure 130 to 139 by 80 to 89 millimeter of mercury. If blood pressure remains uncontrolled at 3 to 6 months after non-pharmacologic treatment, consider starting pharmacologic therapy. A new idea about the acute respiratory distress syndrome is a potential fatal condition involving lung damage, and experts often associate it with severe COVID-19. A recent study which appears in the Journal of American College of Cardiology reports that metoprolol can reduce the lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Lowering the systolic blood pressure target down to 110, as SPRINT trial has shown, is again emphasized by the STEP randomized trial. This is a Chinese trial for a Chinese population in the age group of 60 to 80, and about 8,500 patients were enrolled. The intensive target trimmed 26% of the composite CV events. Findings from new second major trial supporting a lower target could unite the guidelines, which even among the US professional societies range the threshold to 130 to 150. So we can add it to the new target, that is 110 to 130 systolic blood pressure. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European Guideline on the Management of Arterial Hypertension recommended that diagnosis of hypertension should not only be dependent on office BP, should also be used ABPM and SBPM. SBPM is home blood pressure monitoring and ABPM is ambulatory blood pressure monitoring. Thus, they may be considered as the most relevant measurable for estimating cardiovascular risk. It has been seen the high nighttime BP were associated with greater risk of mortality and composite cardiovascular outcome. Thus, every 20 by 10 millimeter of mercury increment in blood pressure measurement at night, the risk of mortality increased by 23% and risk of cardiovascular events by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal BP control. The 2018 European guideline equally recommended 5 classes of antihypertensive drugs, considering high non-adherence treatment. The importance of combination treatment is particularly highlighted to improve the adherence to therapy and BP control. Therefore, 2018 European guidelines recommend, especially in the context of lower BP target, to start antihypertensive therapy with an initial dual fixed dose combination, that is ACE inhibitor or ARB plus calcium channel blocker or diuretic, preferably in a single pill. Since July 2018, products containing valsartan have been recalled worldwide. The reason for this is detection of a new carcinogen, namely N-nitrosodimethylphenine or NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. This NDMA has been classified by the WHO International Agency for Research on Cancer to be carcinogenic in humans. If 1 lakh people would have received NDMA contaminated valsartan for Jering Hujai study every day for 6 years in a highest dose, it could result in 22 additional liver cancer over a lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. The valsartan recall, accompanied by the significant increase in the rate of emergency department visits, plus 6%. Another study, the HYGEA study, represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy, which associated with significant reduction in the endpoints, that is including death, the HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening antihypertensive therapy exerts a favorable cardiovascular risk reduction. The largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced the primary cardiovascular outcome. An ambulatory BP measurement was performed for 48 hours to collect the data on which BP, on how blood pressure differed during the sleep. The relative risk reduction for cardiovascular event was significantly improved for nighttime treatment when compared with awakening treatment. Thank you for your patient hearing.